Hello, everyone. A very good evening from my side. I hope all of you are doing fine. And is my voice clear and audible to all of you?
Yes, ma'am.
Okay, perfect. So this is the Urogynae module, the module which many of us don't like, right? For some, they like this module, but for some people, they think the module is very tough, but it's not so tough. And we are going to discuss about the few things which we have to do in the uh, like when we take the information gathering and the five we are tested in the how many uh, we know about the information gathering communication with patient safety, applied clinical knowledge, and what else is there in which we are tested, the domains. There are 5 domains, right? So what we will do today, we will be discussing the domains and important points related to the urogynae. And then we will be doing the task, one simulated patient and one structured discussion task. Then we will discuss the urodynamics and graph interpretation. So information gathering, we know it's about history, examination, and investigation. And there has to be correct interpretation of history, examination findings, and investigation, and the results. So in the urogynae, you will be getting the urodynamic graphs. And it came as teaching station and also as structured discussion, right? Then there can be bladder diary in the bladder pain syndrome and in overactive bladder. Food diary in bladder pain syndrome, right? Another important part is inviting questions. Always ask the role player, do you have any questions so far? Next domain is your communication with patient. Very easy domain. Like there has to be appropriate introduction and you have to confirm the aim and agenda of the meeting, ask about the concerns, ideas and expectations of the patient. And how you deliver the consultation, that is also very important. In simulated patient task, there should be no medical jargons. And when you are explaining the conditions, you are not going to use any technical terminology. Your language has to be very simple. Maintain eye contact, and the body language should also be like very nice. You're not going to sit arrogantly in the exam. Of course, we all are like sitting in a very nice way, okay? And be an active and attentive listener. Don't interrupt the patient when she is giving you the informations. And you can also draw and explain. So that is also a good part of communication. Like when you're explaining about the pelvic organ prolapse, you can draw that. See, these are your pelvic organs. We have the bladder, the uterus, and the back passage. And suppose there is a rectocele, then you can say that there is the bowel, the part of the bowel has come down, and we call it as rectocele in medical terms. Communication with patient also means giving the patient information leaflet, and when you're closing the station, telling the patient about the follow-up appointment. Being honest with the patient is important, particularly if there is clinical uncertainty about surgical or management option. Like we know patient asks about the mesh these days. That doctor, are you going to use the mesh in any incontinence surgery or prolapse surgery? So now we know that mesh is not used. It is only used in the clinical settings. So suppose you're not able to recall any such information, tell the patient honestly, at the moment, I'm not aware of it, but I'll talk to my senior, I'll talk to my consultant, and then I will get back to you. So suppose she asks about any percentage, the success rate of any operation like colposuspension operation or sling procedure surgery. Suppose you don't know at the time. So be honest and tell her that at the moment, I'm not aware of that, but I will talk to my senior and I'll get back to you. Okay? Because RCOG wants honest doctor. So you have to be honest. You are not going to make any of your own answer. And also tell the patient if certain medicine is unlicensed, like in bladder pain syndrome, cimetidine is unlicensed. So you have to tell the patient about that. And you should also explain the conditions in a simple language, explain the test results and management plan in a simple language. Again, no technical terminology in simulated patient tasks. Give the information in small chunks and check the understanding. Am I clear so far? Do you have any question? That pause is very important in the exam, because if you will give a lot of information without any pause, and you will follow your own agenda, then that's not going to help you. You have to give the pause, invite the questions, and after giving some informations, pause and ask about the patient's understanding. Communication with colleague, very easy domain to pass. Any complicated case involve your seniors, and other specialties, the MDT. Discussing the differential diagnosis and appropriate management plan, that is your communication with colleague in structured discussion tasks. Writing to GP. If any GP letter is given or the patient has been referred by the GP, write back to the GP. You will get the marks, right? What about the patient safety? Very, very important domain for the Part 3 exam. For any procedure, take the informed consent from the patient. When you're discussing about any result, check the patient's ID, name, date of birth, NHS number. For any procedure, when you're explaining the procedure, that is the applied clinical knowledge. But when you're talking about the risk and complications, that is the patient safety. For example, we know in overactive bladder or urge incontinence, we are giving the Botox injection. So telling the patient about avoiding dysfunction and use of clean intermittent self-catheterization, so that is patient safety. Also telling the patient about any procedure, that procedure will fail, or if we have done the surgery for the prolapse or incontinence, then telling the patient about risk of recurrence is also patient safety. Before any procedure, rule out any contraindication. For example, very simple example, in urodynamic studies, if the patient is having UTI, that is like a relative contraindication. So first we have to treat the UTI, only then the patient can have the urodynamics. Okay. What about the MDT? Again, this is patient safety as well. So MDT is your communication with colleagues and MDT is patient safety. Applied clinical knowledge. Well, you people have cleared your part 2, so you have the knowledge. Now you have to apply the clinical knowledge. So you have to apply the knowledge as per the green top and NICE guidelines. So in the Urogynae, we know there are first line, second line, and third line management options. So you have to know those, like the flow charts are given there. So you have to know the flow charts. And MDT meetings, we know about the MDT meetings, particularly in stress urinary incontinence before the surgical treatment, or in failed conservative and medical management, and patient has to go for surgical management in detrusor overactivity, urge incontinence or bladder pain syndrome, then MDT meeting is important. So the thing is that these patient safety and applied clinical knowledge, they go hand in hand. The management part, explanation is applied clinical knowledge. Telling the risk and complications of any procedure is your patient safety. Telling the risk of recurrence, failure of the procedure, that is also your patient safety. And you should know that how much information you have to give to the patient. So that comes with practice. And that is why we say practicing is very important for the preparation of the Part 3 exam. You all should have a study buddy and practice the stations. Initially 2-3 stations in a day, make it 4 on your Off days, do 5 stations. So initially, 4 to 5 stations are enough. So let's practice the stations as well. Now I will need volunteer. So who would like to come first? Stations are simple. Please, if you want to, first one is simulated patient task. This I can tell you. Okay, so someone can come forward. You want to see the question? Who wanted to do? Actually, someone told me that day that they want to do. Sanchita is here and Mahrukh. They told me that they would like to do. Someone is writing in the chat box. Let me see. Sanchita. Yes, Sanchita. All right. Can you unmute yourself, my dear Sanchita?
Yes, ma'am.
All right. Good. Your voice is clear. Take you 2 minutes. You have 2 slides. Okay.
নিতু দরজাটা একটু বন্ধ করে দাও, দরজাটা বন্ধ করে দাও আর আমার ইয়ে করো, এসিটা ছেড়ে দিয়ে যাও। আমি এখন একটু ক্লাসে। হ্যালো হ্যালো
Yes, yes. Hello. Yes, Sanchita. Next slide you want to see. Others, please keep yourself muted because many participants are there. I don't know whom I should mute, and Sanchita is unmuted right now. The rest of you, please keep yourself muted. Okay. Sanchita, if you want me to change the slide, just let me know. Okay. Next slide, you will see I'm changing it for you. Okay. This one.
I have not yet read the first one. Would you please, as I have joined a bit later, I want to see the first one.
First slide.
Thank you. Thank you.
Take your time.
Okay. Second slide, please.
Yes.
Okay. Is there any more slide?
No, my dear. Would you like to start?
Thank you. I will go for the first slide.
Okay, here it is. Start, please.
Okay. Hello, I'm Dr. Shojita, one of the doctor covering the urogynecology clinic today. May I confirm your name and age, please?
Yes, I'm Jane Smith, 35 years old.
Jane, how may I address you? How would you like to be addressed?
Call me Jane.
Okay, Jane. Jane, I have been seeing that. I'm so sorry that at first I would like to apologize you that you have been waiting for an hour. I'm so sorry from my side.
Okay.
If you want, then I would continue our conversation.
Yeah.
Is that all right?
Yeah, that's all right. But I hope next time I don't have to wait for so long because, even my time is very precious.
Yeah, absolutely, that Jane. We will look it into the matter that that this happened. This thing would not happen in the future. We will look over that. Jane, from your GP letter, I came to know that you are in your second pregnancy and at your 30 weeks, and at the same time you are complaining of something a lump in your vagina. And is that okay?
Yes, and this lump is bothering me too much. And
Sorry to hear that.
I'm also having some heaviness down below.
Okay. Apart from this, do you have any other concern to address?
No.
Oh, okay, Jane. For the next few minutes, I would like to ask you a few questions to know more about you. And following that, we would like to we would like to plan a safe, acceptable, and manage a safe, acceptable, and mutually agreeable plan for you. How does it sound?
Yeah, that's fine.
Can you tell me in your own words what in your words about your problems?
Yes. Actually, I noticed this lump down below and some heaviness for the last 2 months. And because of that, I'm having some discomfort also down below.
Okay. Do you? Sorry to hear that. Don't worry. Me and our team are here to find a solution for this. Do you feel any type of discomfort for during passing your urine?
No, but not discomfort. Actually, I go to pee more frequently these days.
Or how many times
Just a minute.
in a day you have to go for pee?
Who is unmuted? Please mute yourself, please. Okay. Yes, Sanchita? Your question again, please.
How many times do you have to go? How many times do you have to go for pee in a daytime?
Yeah, I think it's about 8 to 10 times sometimes.
Does it makes you wake up at night also?
Just one time in the night.
Okay, I'm noted it down. Do you have any rush to the toilet?
No, not at all.
Any leaking before reaching to the toilet?
No.
Do you have the leak during sneezing, coughing, or any effort?
No.
Okay. Is there any form of burning sensation during your pee?
No.
Is there any problem with opening of your bowel?
No.
Okay. I can see that it is affecting your quality of life, isn't it?
Yeah, yes, because because of the lump, I have this discomfort.
Okay, Jane. Jane, at the same time, I can see that you are pregnant for about 30 weeks.
Yes.
Is it?
Yes.
And this is your first pregnancy?
No. This is my
Sorry, this is your second pregnancy. This is your second pregnancy. And what about your first pregnancy?
First pregnancy was absolutely fine, no problem at all.
How the baby was delivered?
Baby was delivered with the help of forceps, the big spoon-like instrument. And my baby Sam was about 4 kilograms.
Okay. How was the recovery following that?
Yeah, that was fine.
Okay. Do you name your baby?
Yes, he is John.
Of this baby you are carrying now? Okay. Do you feel John's movement?
Yes.
Okay. Are you are you otherwise fit and healthy?
Yes.
That means that do you have any form of like high blood sugar or raised blood pressure?
No, no.
Okay, what do you have? No. Do you have any surgery in your past?
No,
Any family history of concern?
no.
May I know your height to weight ratio?
Yeah, it is 30.
Okay. At the same time, some of my question regarding your personal behavior, like that, do you smoke?
Well, I do, but now I'm trying to quit smoking.
So I'm very happy to know hear that as you know, you are aware of that smoking is harmful for your pregnancy also, and you are do you attach to the NHS stop smoking services?
Yes, GP has attached me to that.
Oh, okay. I'm. Do you take alcohol?
No, I stopped it completely.
Congratulations. Pardon me to ask, any type of recreational drug?
No, never.
Okay. Um, what do you do for your living?
I'm a housekeeping actually,
Okay. How's your support? Whom do you live
with my partner.
How's your support at home?
Yeah, David is very supportive.
Okay. Do you feel any type of low down or depressed in the last few months or weeks?
No,
Are you allergic to any medication or any food?
no.
Are you aware of your blood group?
Yes, A positive.
Okay. Thank you, Jane, for the information you have provided to me. Do you want to add anything more?
No.
Okay, Jane. Jane, in the presence of a chaperone, I would like to examine you. Already, my nurse have taken your general, taken your blood pressure, pulse rate, and also they confirm your height to weight ratio. And at the same time, your your baby's condition, that is your height in your tummy, and also the baby's heart rate also given to me. And at the same time, speculum examination which is done in your private parts in the presence of a chaperone also provided to us. And from the history examination, I can confirm, I can see that you are a pregnant woman in your second pregnancy at your 30 weeks with a condition which we usually call a cystocele, and that is in the stage 2. Are you with me?
What does it mean, doctor?
Jane, I am explaining you. Cystocele means that you think that if you like, I will draw for you. See that it is your womb, and in the front of the womb there is the water bag, and in the back there is the back passage. Due to for some condition, as you have already stated me that your first baby was delivered in the instrumental delivery, and there was a cut in your private areas. And regarding of this condition, there may be your water bag which lies in front of your womb may comes out from in the down below. Are you with me?
Okay, I see. Yes.
And this condition causing you troublesome in your lower heaviness in the down below. And but you have no other you have no other problem in your back pieces, and not any descent of your womb also.
Right. Okay.
But Jane, I think that as you are pregnant at this condition, we will go for only for the we will now. Would you like me to continue for the management option?
Yes.
Yes. As you are usually in the non-pregnant state, we usually go for the at first that there will be some type of lifestyle modification. Your BMI is at the little bit higher side, that is 30 kg per meter square, and we will try to. Oh, sorry, I have come.
Okay.
Lifestyle modification, which will include that your BMI is 30 kg per meter. BMI, that means the height to weight ratio is in the is in the higher side, that is 30 kg per meter squares. At first, I would like to ask you, after pregnancy, after pregnancy, we will usually advise you to reduce, cut down some of the pound. That will also make this condition affordable. And at the same time, we will also we can also tell you to do some exercise, which usually call the pelvic muscle floor exercise, which is usually 8 contraction 3 times a day, which also provide you to improvement of the tone of the muscles of your private parts and help you to come out of this condition temporarily. As you are pregnant, we cannot go for any type of surgical option at this moment. Are you with me?
Okay, so I cannot have surgery right now or after delivery?
After delivery, we will assess your condition again, and if after delivery, if the condition also bother you, then we can go give you the surgical option, that is the repair of the anterior wall of your vagina wall. And this operation is called the anterior colpoperineography.
Anything else can be done during the pregnancy? Your time is up, but please continue. Yes.
I think we can also rule out the also pessary can be given.
Yes. Mm-hmm.
And pessary can also be given.
Can you tell me more about the pessary?
Yes, pessary is the there are different mode of pessary, but in your case we can use pessary for about for the rest of the period of your pregnancy, which will support your of this cystocele and to become support your cystocele and keep it in the position so that it will not come down and make you feel comfortable, and it will also help you to evacuate your pee easily. And when the pregnancy is over and before the delivery time, it can be easily removed out, and you can also our GP clinic, or we will also learn you how to take care of the pessary, how to remove it, and also place it in the further. Are you with me?
Yes. Okay.
And the definitive management of this condition is the surgical management, which we will talk you more about it after your delivery. Until now, I think that I have given you a lot of information. Do you want to know anything more?
No, thank you.
Jane, I will give you some patient information leaflet about this condition, and if you you read that, and if you want to know anything, then come back to me. Don't hesitate. I will am always here to answer your question. Thank you, Jane.
Okay, thank you. Okay.
Thank you.
Okay, thank you, Sanchita, my dear. Well done. Talking in front of so many people, live presentation is not easy. So hats off to you and good presentation, because I know you people are in the initial stage of your preparation, going for the November exam. So I was not expecting also a very fluent presentation. Overall, it was nearly fluent presentation, nearly up to the mark, my dear. Okay, so what was this station about? Pregnancy and pelvic organ prolapse. Mainly it was cystocele. What was...
I only prepared myself about the pelvic organ prolapse, cystocele, but not associated with pregnancy.
Not associated with pregnancy, yes. I brought this pregnancy. Yes, Sanchita, yes. But well done, my dear, well done. Talking and speaking really makes a difference. And for the part 3, you have to speak, you have to talk. Just reading and not talking, going through the books and like sitting calmly and silently is never going to help. You have to come forward and speak. Well done, my dear. I brought this station. Why? Because there's a
Is it okay, Dr. Shabana? I think that I have to improve myself a lot, but as the first presentation and as the scenario is completely unknown to me.
Yes. Yes, we will discuss, my dear. You managed the station. The management part was absolutely fine. History was little long, and we will discuss the time management and everything. So
okay. Now I can mute myself.
Yes, you can mute yourself. If any questions in between, please unmute and ask. Okay.
Yes.
So what I was saying,
Okay.
Okay, Sanchita. Thank you, my dear. What I was saying, why I brought this station, because we have a talk, and that talk is the urogynecology problems during pregnancy and postpartum. So postpartum station is very famous these days. Postpartum urinary retention, everyone knows about the station. So if there can be some stations like prolapse in pregnancy can be asked, prolapse in the postpartum, or urinary incontinence in pregnancy and after delivery, these stations can come. So when you are seeing any scenario, you have to see the domains which you are being tested, information gathering. Yes, you people know it very well. Communication with patient. Yes, communication was absolutely fine, Sanchita. You apologized in the beginning. Well done. Patient safety and applied clinical knowledge. Actually, when you started talking about the management, the bell rang. Okay, so your applied clinical knowledge, the management part was after the bell rang. So how to make the history short, we will discuss that as well, so that you can at least finish the important management parts within 4 minutes at least. Because we know introduction, aim, agenda, asking the patient about the concerns, it takes your 1 minute or something. Information gathering part, examination part, it takes another 4 minutes. And 1 to 1.5 minutes, the patient, the talk in the exam. And now you have to see in 10 minutes what you have to do. So you have to take relevant and focused history. It is like your open questions. So regarding the waterworks, my dear, you can ask just one line. Do you have any problem with your waterworks or bowel opening? She will say no. No problem at all. Just I have a lump down below and sometimes I pass urine more frequently. So if she says, no, I don't have any other problem, plus the examination finding is given, she has cystocele, nothing else, then don't think there is any hidden agenda. Then you have to make your history short. You don't have to ask about, do you rush to go to toilet, or do you leak before you pass urine? No, she told you about the problem that I go to pass urine more frequently, which is quite common during the pregnancy and also with the cystocele. Nocturia, it can happen. Yes, once is normal. Then what is your next task? Explain the examination findings. Here already examination finding is given, so you just have to explain that. Now you don't have to examine her again. Address her concerns. I asked you, can I have surgery now or after the delivery? So not during the pregnancy. And regarding the surgery for prolapse has to be done only after your family is complete. So in the ops history, ask how many, like, what about your future pregnancy plan? Okay. Then discuss the management options. So management option will be like a mini agenda, which will tell her that simple measures, lifestyle modifications. Then we have the exercise, pelvic floor muscle exercise, pessary. Okay, these are the management option for you as of now. Regarding the surgery, only after your family is complete. All right. So let's discuss the answer. All right, so your communication was fine, my dear. It will be your introduction. Hello, I'm Dr. Sanchita, one of the doctors in the Urogynec clinic today. May I confirm your name and age, please? How may I address you? Thank you, Jane. Then apologize first, which you did. So you will say that, Jane, I can see that you have been waiting for an hour and I'm sorry about that. I apologize for that. So is it okay if we carry on with the consultation? Because after that, you have to seek permission to continue with the consultation, which you did. Yes. Then comes your aim of the meeting. I can see that you have been referred by your GP and you're 30 weeks pregnant, and also you have a lump and heaviness down below. Am I right? Is there any other concern which you want me to address today? Asking about the concern is very, very important. Then set your agenda. All right. So in a moment, I'll try to address all your concerns. Before that, is it okay if I ask you a few questions? I may need to examine you, and then I will discuss the management options. Will that be okay? I will also be giving you the written information leaflet and write back to the GP. Is that fine? So when you're talking about writing back to GP, it is communication with your colleague. Then comes your information gathering part. So it's going to be the open question. So you can ask about the condition. Can you tell me more about your condition, about the lump and heaviness? So since when did you notice? Was it there before the pregnancy? Anything that makes it better? How about anything that makes it worse? How about your waterworks and the bowel opening? Just one line. That's all. Maybe she will just tell you that I go to pass urine more frequently. That's all. No other problem. Bowel opening, no problem at all in my bowel opening. Asking about the quality of life is important. Is this condition affecting your life in any way, and how are you coping? Inquire about the current pregnancy. Again, the open questions. Can you tell me more about your pregnancy? Have you named your baby? And can you feel John's movements? Many congratulations. Congratulate her, because there isn't anything which is very serious at the moment. Then, a little bit of gynae history. Have you noticed any abnormal vaginal discharge? How about your cervical screening? Was it up to date and normal? Then, sexual history. After signposting, you will ask her, is this condition affecting your, I would like to ask you some personal question, is this condition affecting your sexual life? She is gravida 2 para 1, so you have to ask about the previous pregnancy and delivery. Again, the open questions. Can you tell me more about your previous pregnancy and delivery? So it was vaginal delivery, and how was it? So if she says the use of instruments, okay, then baby's weight, inquire about the breastfeeding and recovery. What about your future pregnancy plans? This is important because in her case, we are not going to do any type of surgery before the family is complete. Medical history, always ask, do you follow GP for any medical condition like, in her case, cough or constipation? High blood pressure and diabetes, okay, you can ask, but in her case, in the urogynae cases, ask about the cough and constipation. Are you on any medication? Do you have any allergy to food, drug, or substance? Any surgery on your tummy or down below in the past? Because this could be recurrence of the prolapse. Maybe she had a prolapse surgery before. Any family history of concern? May I know what you do for a living? I told you I'm a housekeeping. So do you lift heavy weights? Do you stand for long hours? Yes, I do. Then you have to address these issues as well, because this is also a cause of the prolapse. How about your partner? And how about the support at home? Because you have to rule out domestic violence, you have to ask the question. Social history is important. Asking about smoking, and you did ask, so how many cigarettes per day? 5 to 6, so, or even 1 to 2, then tell her that smoking has no health benefit. So with your permission, we can put you in touch with our NHS Stop Smoking services. Alcohol also during the pregnancy, there is no safe limit. So if she is drinking, you will put her in touch with the alcohol stop services. Any recreational drugs, mental health history. Have you been feeling lower down in the last few weeks? Would you like to add anything important? Then tell her thanks for these informations. Okay. After that, coming to the examination. So if no examination finding is given, then you can say, I would like to examine you with your permission and in the presence of chaperone, just to assess your general health. Examine your tummy to see how your baby is doing, and from down below to see what exactly is causing the heaviness and to assess the size of the lump. Now here examination findings are given, so you can explain the findings. You will say that I have your examination findings right in front of you, and right in front of me. Here in the exam, you can just tell her once that, is it okay if I examine you, just to see if there is any new findings. So maybe she will say, no, GP has already examined me and these are the examination findings. All right, then confirm the ID. I have confirmed your name, date of birth, and NHS number. And I can see your blood pressure and heart rate is normal. Your weight-height ratio is 30. Are you aware of that? Have you been trying to lose weight? The tummy examination was done. Your baby is in the head down position and the baby's heartbeat is heard. And also examination was done from down below, and I have some concerns regarding this examination. Now, what are the concerns? I can see that your bladder is bulging into the front wall of your vagina, and this is causing the heaviness and lump down below. We call this condition as cystocele in medical terms. Have you heard about it? All right, then Joanne explains that we have the pelvic organs. This is the bladder that stores urine and uterus in front and the bowel behind. So they understand the bladder and uterus. Okay, so if you say the water bag and the womb, even that is fine. These organs are held in place by supporting structures, the muscles and ligaments, and with repeated deliveries, these supporting structures become weak and organs bulge out. And during pregnancy, there are hormonal changes. They can weaken the supporting structures. In your case, the bladder has bulged out from its normal place. Am I clear so far? Any question? Now, coming to the management, you will tell her, all right, so is it okay if I discuss with you about the management? We have the simple measures like lifestyle modification, some special exercise, and vaginal device like pessary. So I'll discuss about them one by one. So regarding the simple lifestyle modifications, if she has constipation, tell her try to avoid constipation, and for that, we will refer you to the dietitian so that you can have healthy diet, rich in fiber. And also you can use the stool softeners like glycerine suppository, keep yourself well hydrated, drink plenty of fluid. If she has cough, tell her it has to be treated, and you can ask your GP for the medication. If she's a smoker, smoking cessation advice has to be given. If you have already advised before, no need to repeat. She is a housekeeping, very important patient safety point here. You have to tell her, please avoid lifting heavy weights and standing for long hours. Otherwise, this can increase the size of the bulge more. And regarding your weight-height ratio, as it is 30, it is on the higher side. So we would advise you to lose weight after pregnancy, because during the pregnancy, we don't advise to lose weight. Only avoid gaining more weight during the pregnancy. Then coming to the exercise, tell her there are some special exercises. They will help to relieve your symptoms by strengthening the pelvic muscle. For that, we can refer you to the physiotherapist who will supervise you to do these exercises. So this is your communication with colleague. So here you don't have to say the 8 contractions and 3 times. Keep it simple. Okay. She will ask, are these exercises safe in pregnancy? Yes, they are safe in pregnancy. Okay. Tell her about the pessary, that we have a small device made of plastic, silicone or latex. It is inserted into the vagina. It helps to keep the bulge in place and improve symptoms. It comes in different shapes and size. And before insertion, we will examine you to assess the correct size for you. Would you like me to tell more about the pessary? So if she says yes, it means that there is some marks in the pessary. So follow her agenda. Then go on with the pessary. So after the insertion, we have to ask you to come for the follow-up so that it can be removed and cleaned and reinserted. We will teach you how to remove and reinsert it. Then tell her about the risk. This is the patient safety. What happens with the pessary? It may get pushed into the vagina. Sometimes removal can be difficult. It can cause raw area which can bleed. And during your follow-up visits, this will be checked. What about other risks? Sometimes the bulge can become big during the pregnancy, so we have to change the size of the pessary. Sometimes the pessary can fall out. However, we have seen that it is quite effective in improving symptom. Any questions so far? All right. Now, if she asks, can I have surgery for this bulge? Okay, I do appreciate your concerns regarding the surgery. Then you will tell her you can have surgery after your family is complete, because if you get pregnant again after the surgery, then there are risks. The surgery can fail and the bulge can come back again. Then you will need another surgery. This will not be as effective as the first one. Repeat surgery will be difficult to perform due to presence of scar. Am I clear so far? Okay. And then what about my delivery, doctor? Yes, you can have a vaginal delivery. After the delivery, the bulge can increase and you will be asked to continue doing the pelvic floor muscle exercise. Vestry can be reinserted. And so after this, giving this much information, just again ask her any questions so far. Is there anything which you want me to repeat again? No. All right. So I know I have given you a lot of information. So I will give you the rich information leaflet about your condition and the management options we have discussed. I will discuss your case with my consultant, refer you to the dietitian and physiotherapist. So would you like the insertion of pessary? If she says yes, okay, then tell her we will take the swabs and give another appointment for pessary insertion. Any more question? No, thank you. Okay, so anything else? All right, after that we will discuss another scenario. So this, okay, someone has written in the chat box, please last slide. This slide. I will share the recording, don't worry, okay. So we have one more scenario, similar scenario. 1 minute. So any questions so far, Sanchita, in your station?
Key.
All right. So the TOG is important, my dear. In the TOG, very nicely, they have given about the conservative managements during the pregnancy and after the pregnancy. And surgery, they have written after the family is complete, both in cases of pelvic organ prolapse, cystocele, rectocele, or even in the incontinence. So we have another question here. Patient had a previous pelvic organ prolapse surgery, okay? Suppose this patient whom we are discussing about, she had the surgery, that is the anterior repair for cystocele, and now she is pregnant, although she was advised against pregnancy. How will you counsel her regarding the effect of pregnancy on prolapse surgery and on prolapse itself and the mode of delivery? So I just need the management part. History taking part will be the same. Can someone unmute and tell me just 4 or 5 lines? That's all. What do you think will be the effect of pregnancy on the prolapse surgery or on the bulge itself? What happens? What will happen to the bulge, the prolapse during the pregnancy? It will increase in size, right? And what about the mode of delivery? Okay, so what happens? That effect of pregnancy on the prolapse surgeries is still not known. In the pregnancy, there are many hormones like progesterone and relaxins are secreted. They can relax the structures, the ligaments, and the muscles. So they can affect the surgery. What happens to the prolapse? The bulge will increase in the size. So during the pregnancy, we have to offer you examination and keep an eye on the bulge. What about the mode of delivery? So if the bulge occurs again, because the patient had prolapse surgery before. So at the moment, there is no bulge. That is why we have to examine. So if there is bulge, then offer vaginal delivery. If there is no bulge, then we can offer cesarean section. Someone is writing here, yes, so unmute and say, my dear, it will worsen. Yes, Rekha and Sanchita vaginal. Yes, yes, my dear. So why don't you just unmute and say, okay, it depends upon presentation and delivery. What presentation? Someone is there with the name of Ummul Khair. Okay. All right, fine. So just unmute and speak up, my dears. This is just a discussion, nothing else. What about the counseling part? So effect of pregnancy on previous surgery, this is not known. Pregnancy hormones can affect the surgery. Effect of pregnancy on the bulge. So the bulge can come back again during the pregnancy. It can increase in size as the pregnancy advances. So during the pregnancy, we will be following you up. What about the delivery? So if there is no bulge during the pregnancy, consider cesarean section. Why? To avoid the strain due to pushing during delivery. If the bulge has come back again, then offer the vaginal delivery. One more important point, and then in the exam, you can discuss the pros and cons of the vaginal delivery, cesarean section, give her the patient formation leaflet. You can involve your consultant in this case, and she will be booked in consultant-led unit. Tell her about the use of effective contraception and to avoid any pregnancy after the surgery. All right. Baby's presentation. Yeah, baby's presentation will be there. Okay. But here we are talking about the bulge. All right.
Dr. Shabana, can I ask you one question?
Hmm.
Yes, doctor, for you advise her consider cesarean section. Why? I mean, even if the recurrent, either simpler procedure to repair again rather than to go for open surgery for cesarean section. I mean, she is not in for perch colpo suspension, which is difficult operation and specialized
We're
operation.
talking
And
about cystocele. We're not talking about the bush corpus suspension.
yeah,
So,
for perch usually cesarean, we'll go for cesarean after that because risk of damage to the bulge colpo suspension and it's big surgery and stress incontinence compromise life. I mean, for a cystocele, shall we consider cesarean section?
no,
If
my
she,
dear, read what I have written here. If the bulge doesn't come back,
yeah, I understand
yes,
that.
yes, no bulge, then consider cesarean section. Because what will happen that with vaginal delivery, she already had an operation. With vaginal delivery, there is very high chance that the bulge
Yeah,
will come back again.
I get
The
the
bulge
patient.
comes back again, then she will need another cystocele repair.
Yeah,
That will not be very effective. It may fail.
yeah, because Oscar, you say Oscar, yeah,
Yes.
correct.
Yes.
But I mean, yeah,
Yes.
doctor, I understand your
This is evidence-based. Just
oh,
open the TOG and see.
yeah,
The
yeah,
new
yeah,
TOG on the Urogynae.
okay,
So only because now this patient had surgery for the cystocele. Cystocele
yeah,
was detached. Okay.
yeah.
She was advised strongly, you're not going to get pregnant. No pregnancy, because even during the pregnancy, because of the hormones released, it can affect the surgery. Okay.
Yeah,
So
I get it.
keep an eye on the bulge during this pregnancy. If the bulge does not come back again, so to prevent the bulge from happening again, we have to consider cesarean section. Now, if already the bulge is there, then okay, she can have the vaginal delivery. And then she will gain the surgery.
Repair.
All right?
Yeah, doctor, I get it. So you told me it's space evidence, last talk. Yeah, okay, that's why. I'd consider cesarean section as not offer. It's considered. Yeah,
Yeah.
doctor, thanks.
May I know your name, please?
Thanks, doctor.
Yeah.
Anna.
Anam. Okay, my dear. All right. Okay, so we have a similar scenario here. Okay. Now, this one patient has been diagnosed with stress urinary incontinence in pregnancy. BMI is 30, history of cough. She's a smoker. How will you counsel her regarding the management options? Because history taking will be same. Even the management option part is going to be same, nearly same. So can someone unmute and speak? Please don't write in the chat box. We are just discussing. Just unmute and...
Dr. Shabana,
Hmm.
would you please share the talk for us?
Yes, the new talk. I think we have shared it so many times in the case discussion group. I will share it again.
Okay, thank you.
Yes, yes. That new talk, the famous one, you know, the one which has urogyne like effect in the pregnancy, postpartum, and the postpartum urinary retention talk, the postpartum voiding dysfunction talk. Offers cesarean section. Okay, no one wants to talk. Okay. She has been diagnosed with urinary incontinence in pregnancy. So when you are managing her, again, you will start with the simple things. Okay. Lifestyle modifications. For the cough, you will address the cough. Stop smoking. BMI is 30. Tell her to reduce the BMI. Okay. And pelvic floor muscle exercise, the pessary. Management option. What else? Cesarean section? No, my dear. During the pregnancy, it is only conservative management. Okay. All right. So just have a look at our answer. We discussed the conservative management still here. Okay. Any surgery for incontinence or pelvic organ prolapse only after the family is complete. And for the incontinence, tell her that after the delivery, with the conservative managements, the condition can improve. And it has been seen that condition improves in about 6 to 12 months after the delivery. Okay, so no need of cesarean section. She can have vaginal delivery. All right, then second scenario. Now this lady who was having stress urinary incontinence in pregnancy, now she had a surgery. All right. Again, she is pregnant despite advising against pregnancy, and she is again having recurrence of stress urinary incontinence during pregnancy. Same treatments, my dear. Okay, conservative and surgery again after the family is complete. But here, in her case, she had a surgery and now she's having the recurrence of the symptoms. So for her also, we are going to give the same advice that postpartum, continue your conservative treatments, the pelvic floor muscle exercise and pessary, and symptoms will resolve in about 6 to 12 months after the delivery. Okay, so she may not need another surgery for the stress urinary incontinence, because we know that incontinence is also like stress incontinence is also common in the pregnancy. So even after delivery, she is going to wait for about 6 to 12 months. Am I clear so far? Any questions? This is all from the
Yes,
top.
Doctor, you are clear. Yeah. Because you mean it's during a pregnancy, it's spontaneously, it might be she got because of pressure, she got stress incontinence. So if she has, but if she has birth colbo suspension, so she will go for cesarean section after if she gets pregnant. This
Yes,
is my
that is the major. That is the major surgery which she had.
Yeah, another.
But the thing is that we are always going to wait, right?
Yeah, yeah.
Because even cesarean section is major surgery, and we are going to do it for the obstetric indications, right?
There's adhesion with birch. Probably there is adhesion with birch. Yeah.
And postpartum, she will wait for 6 to 12 months because the condition can resolve on its own. Maybe she will not need another surgery. Okay, fine. Okay. All right, so next. Next, we have structure discussion task. Who would like to volunteer? Okay, see the question, structure discussion sometimes, because you people are like, I don't know, some of you might have given the exam before. Some of you are going for the exam for the first time. So this is the structure discussion task. But I will need someone to come forward and talk. I have a YouTube video also on this. I have brought this station because it's something very important. It can come in the teaching. It can come as structured discussion task as well. Anyone? Any volunteer? So,
May I try?
yes, who is this, my dear? Dr. Husne Ara, is
I am
it?
Sanchita.
Okay, you're Sanchita. Fine. Yes. And then you have these graphs. I mean, you have to explain this one, the graph. Okay. All right. I'm going back to the first slide. It's interesting station. Very important structure discussion task. Once you are done with the reading, tell me.
Only one slide?
No, I have few more. Just have a look. You have to explain the diagrams, okay? So when you will be talking, the diagrams will be in front of you.
Hello?
Yes? Then you have to talk about graphs.
Screen is not showing. I think in
No, I'm changing the screen. It is okay. Can you see now? Can you see the graphs?
no. I think internet problem.
Others can see the graph.
Yes, doctor, it's clear.
Yes, it's showing to me.
Maybe internet is slow or whatever.
Yes,
Oh,
ma'am, we are able to see.
Okay.
Yes.
All right.
Next one.
Yes, 1 minute. Okay, there's one more graph which you will explain.
Would you please show me the first one?
First page.
Yes.
Okay. This is the main
Okay.
page, right? If you are ready,
Yes.
start. All right. Yes, start, please.
Yes. Yes. I can start now.
Yes, okay.
Okay.
Hello. Yes, Sanchita, start.
Hello.
Mhm.
Hello. Me, Shonchita, register, ST5 register. I have read the instruction and I am ready for the structure discussion.
All right. So explain what is simple urodynamics and its indications.
The simple aerodynamics indicates that it will usually use to see the any problem in the lower urinary tract function, and its indication are we usually do it after the failure of the surgery for stress urinary incontinence when there is apical or anterior prolapse, and after the conservative management of the for detrusor overactivity has been failed, and before that we usually did it, and we also did it when there is the when in the nature of the incontinence cannot be find out, and also in the voiding dysfunction.
Okay, and explain how it is done.
In the urodynamic, it has usually three parts. One is that is the uroflowmetry. Then it is the non-invasive one, and there is also the cystometry and urethral pressure profilometry. It is it is a two phase. One is the filling phase and one is the voiding phase. At first, the calibration is done. That is usually started from the 0, and in the filling phase, normally there are different type of there are two transducer are usually used. One and catheterization is also done. One transducer is inserted into the urinary bladder, and it is usually filled with the normal saline, and it will measure the intravesical pressure, and another transducer is introduced into the rectum, and it will measure the intra-abdominal pressure and the diastolic pressure. We have to calculate it out by subtraction by the intravesical pressure, subtraction the intra-abdominal pressure from the intravesical pressure. We will usually find out the detrusor pressure, and usually the uroflowmetry urodynamic curve is a bell-shaped curve.
Okay. And next question. All right. How you will reach? I mean, we have the graphs here. Okay, so can you discuss about the graphs?
Okay.
What do you think this one is?
This one is, let me explain.
Okay.
I think patient's name and the date of birth. I've confirmed the patient's name and NHS number. I think it is a
in the filling phase.
Detrusor. Yes.
You will see first in the filling phase. Is there any rise in pressure anywhere? This one is the vesical pressure, the purple.
This one is the vesical pressure.
So
and at the voiding phase there is, which is usually normal.
Exactly, it is normal. Very good. What about the abdominal pressure, my dear? Anything?
No, I think it is the artifact.
Yes, you can say that.
At the voiding phase.
Any significant rise in pressure anywhere? No.
No.
You're right. What about the detrusor pressure, my dear? Any significant rise?
It is also normal. There is no detrusor pressure increase. That is excellent. That is the normal urodynamic.
Normal urodynamics, because we have to see the filling phase. There shouldn't be any detrusor overactivity, no detrusor contraction.
And no increase in abdominal pressure or no.
Yes. In the filling phase, the rise in detrusor pressure can be only up to 15 centimeters of water, not more than that. Okay?
Yes.
Perfect.
Less than 15, up to 15 or yes.
Yes, a perfect normal graph, my dear. And no leak has been mentioned anywhere, nothing.
No.
Fine.
And there is no effort-like activity like sneezing, coughing. The patient is not also asked for cough, isn't it?
Right. Yes.
No.
Yes.
Yes.
Dr. Rosina has written normal graph. Yes, my dear. Divya has written, please explain graph. Yes, my dear, we will explain the graph. Don't worry, don't worry. Just let Dr. Sanchita finish the task, then we will explain. Now, Dr. Sanchita, tell me, what do you think about this?
In the next graph, there is no rise in the abdominal pressure in the filling phase, and there is a rise in the vesical pressure and in the filling phase, along with the rise in the detrusor pressure, which is about 54 centimeter.
Any leak mentioned anywhere in the whole graph?
There is, I didn't see any leak.
No. So, yes. What is it?
It is detrusor overactivity.
Yes, because it is high, 54 centimeters.
High, because when there is a rise in the vesicular pressure and there is also rise in the detrusor pressure and no rise in the abdominal pressure, then it is called the detrusor instability, that is overactive bladder. Right. It can be two type, wet or dry, and in this case it is dry type. There is no leak associated with it.
Yes, yes. Now people are writing in the chat box. Okay, fine. This one? Sanchita?
This one mixed, I think.
No. Read
No.
one.
I think there is rise of the vesical pressure and
Rise in vesical
also the
pressure.
detrusor pressure.
Yes, detrusor pressure rises there in the filling phase.
Phase
Anything
and
mentioned somewhere?
ma'am, there is also rise in the abdominal pressure and also vesical pressure in these two
No.
portions.
No, my dear. This is just the desire.
Oh,
Full
first desire.
Rise will be
Okay.
like upward. This one. This is the rise over here.
Okay.
And
there is
leak here.
There is leak.
And leak is associated with what? Which pressure is rising? Which two pressures?
Leak is
Vesical?
associated with vesical pressure and detrusor pressure.
So what is this?
This is
Incontinence. So what type of incontinence?
Urgency, urge leak.
Exactly, urge incontinence. Urge incontinence.
Urge incontinence, yes.
Yes, because when we say detrusor overactivity, that is the urodynamic explanation.
Study, that explanation, yes.
When urodynamic is not done, then we say overactive bladder. But when
yes.
urodynamic is done, then that is the urodynamic diagnosis. So detrusor overactivity plus leak, it is urge.
That is urge incontinence.
Good. Okay. Yes, Dr. Rosina, leak is positive. You're typing. Good. What about this one?
There is vesicular pressure rise associated with abdominal pressure and also leak.
So what is it?
This is urodynamic stress urinary incontinence.
Exactly. Stress incontinence, because we have rise in the vesicular pressure and the abdominal pressure. So this is the urodynamic stress incontinence. That is the correct terminology. Okay, well done. Otherwise, good. At least you came forward. Any more graphs we have? No more graphs. Now we have the answer. So in the exam, you will be having these pictures in front of you, right? Cystometry and your uroflowmetry, the graphs will be given there. Now this station has been coming in the exam for the last, I think, 2 years, isn't it? It came.
Ma'am, this year also come in May exam?
Yes, exactly. It has come. It has come in the May exam also, because the exam goes on for the 4 days. So there will be any station on any one of the day. So last day, I think it came. So it can come as teaching, it can come as structured discussion. Because in this exam, sexual assault, it came on one day as teaching, on the other day, it came as structured discussion. All right, so just be prepared for.
Every station can come in at any form.
In any form, exactly. Yes. All right. Okay, Sanchita, thank you, my dear. Thank you for coming forward. Okay, because I know Urodynamic.
Thank you, Dr. Shabana. You gave me the opportunity.
Yes. It was a nice discussion with you, my dear. And all our friends were writing in the chat box. Good. Okay. So structure discussion, introduction only with your name. I am Sanchita and I'm ready for the discussion. Okay, fine. Someone's camera is on, my dear. Khushwil, please switch off your camera, sweetheart. Thank you. Okay, so what is urodynamics? It is a combination of tests done in an outpatient setting to assess the ability of bladder and urethra to store and void urine. It helps to assess the function and dysfunction of lower urinary tract. We always have to look for any problem in the lower urinary tract. So urodynamics is for the lower urinary tract problems. It helps to confirm or refute a diagnosis. Simple urodynamics is uroflowmetry and cystometry. Mainly these are done. And regarding the ambulatory and video dynamics, they are not done routinely. These are only done in patients with some neurological problems, spinal cord injury, and all those things. Now, what are the indications? So they help to explain the symptoms like incontinence, frequency, and recurrent UTI. Main indications are in cases where conservative treatments have failed and before surgery for urge incontinence, if there is clinical suspicion of detrusor overactivity, if there was previous surgery for continence or prolapse surgery, which has failed now, and there are symptoms suggestive of voiding dysfunction. And in urge incontinence, yes, urodynamic is recommended before surgical treatment, but in stress urinary incontinence, it is not recommended if stress urinary incontinence is clinically diagnosed. But if with stress urinary incontinence, there are some symptoms suggestive of voiding dysfunction or anterior compartment prolapse, which you did say, the apical prolapse or anterior compartment prolapse, or previous surgical management, which has failed, then we will be doing it. Okay, so these are the indications. What about the mixed urinary incontinence? So we have to see which symptom is the predominant one. So if urgency is the predominant symptom, then we will do urodynamic studies, but only after the failed conservative treatment for urge incontinence. I mean, yes, but here, if patient is having mixed urinary incontinence and stress is the predominant symptom, then it is not done. Now, how do we do it? So just give a brief idea about how we do the urodynamic studies. So we have to take brief history from the patient, offer examination, investigations. She should give the consent, informed consent has to be taken from the patient. Give her the patient information leaflet about the procedure. So history, we have to inquire about the symptoms, the severity, which symptom is more bothersome, leak or urgency or both, and whether it is a mixed incontinence. Is this condition affecting the quality of life, whether she's on any medication like anticholinergics, and any surgical history. We have to offer examination in the presence of chaperone and with a permission. Why? To assess for any pelvic organ prolapse, pelvic masses, genital atrophy, pelvic muscle quality and contractility, and urinary leakage. Then offer investigations, urine analysis, dipstick is important. We have to check for UTI and hematuria, because if UTI or hematuria is present, we are not going to do the urodynamic studies. We have to treat this by giving the antibiotics. Very important patient safety. Now, my question is, do we offer prophylactic antibiotic to a patient before urodynamics? Can anyone answer?
No, ma'am.
No, absolutely no. If patient is asymptomatic and she is going for urodynamic testing, then routine prophylactic antibiotic is not given. We have to tell the patient to maintain the bladder diary at least for 3 days, because this will help us to know the leak accidents. So at least for 3 days, right? And uroflowmetry is the simple test which is done in the urodynamics. So you have the diagram given there about the uroflowmetry. So another name is the free flow test. It is done to screen for voiding difficulties. It is a simple test, non-invasive, and relatively inexpensive test. And all these are done in the outpatient clinic. Patient is asked to void by relaxing, not straining. Otherwise, there will be artifacts. So she will just void by relaxing while sitting on a commode over a uroflowmeter. Now you have to explain the diagram. In the exam, you will be given this diagram. Okay, so just explain what it measures. So it measures this voided volume. Okay, and after the voided volume, we have to measure the post-void residual volume. So this post-void residual volume, this is measured either by the catheter sample we will take and measure it, or the ultrasound scan. And then we also see the maximum flow rate. And what about the pattern of flow? It has to be bell-shaped. So what we see here that there will be a rapid upstroke, then a curve with a continuous flow here, and the maximum flow rate here, and then there will be a decline which will end after the micturition. Okay, so only this much you have to explain. Coming to the other one, the cystometry, It is the multi-channel filling and voiding cystometry. What it does, it helps to test the bladder function. It helps to assess the bladder storage ability. It measures the pressure-volume relationship of the bladder during the filling and voiding phase. Now, how it is done? Actually, the idea is to reproduce a micturition cycle. That is the bladder filling and the voiding. At the same time, we will be recording the abdominal and bladder pressure. And attempt is done to reproduce the patient's symptoms to provide a diagnosis. Because this abdominal and bladder pressure, this will help us to know about the detrusor pressure. And detrusor pressure is equal to bladder pressure minus abdominal pressure, right? How it is done? You just have to look at the diagram in the exam that see there are 3 catheters. One catheter is this one, the filling catheter. So this will fill the bladder, okay, with the saline. Then we have the second catheter. It will also be in the bladder and it will measure the bladder pressure attached to the transducer. Then we have another third catheter, either inserted in the vagina or the rectum, to measure the abdominal pressure. And before starting the procedure, we have to measure the resting pressures of vesicle and like the abdominal pressures. Okay. After that, bladder is continuously filled with normal saline solution at room temperature. Then we have to ask the patient about 4 things. These are very important. She will tell us about their first sensation of filling, first desire to void, strong desire to void, and urgency is recorded. Then pressure transducers, these are attached to a computer to calculate the detrusor pressure by subtracting abdominal from the vesical pressure. Okay, so detrusor pressure is vesical pressure minus abdominal pressure. Okay, 1 minute. Now, in the filling phase, patient is asked to do some activities to provoke the bladder. So we will ask her to cough, stand, or jump to provoke the bladder. And we have to see whether there is any detrusor contraction or leakage, because during the filling phase, there should be no leak or detrusor muscle contraction. And then at the end, we have to ask the woman to void to check for the pressure flow analysis. Okay. Now we have to see some more important patient safety points, the pre-procedure checks. You have to check the patient's name and identifier, check the equipment, whether it is working properly, the patient's position. So patient position will be like either sitting or standing position. Setup, like the calibrations are vital in the setup. Calibration should be at 0. Now, if after the simple or conventional urodynamics diagnosis is still unclear, then specialized tests or other urodynamics can be done, which are ambulatory or video urodynamics, which are not done routinely. Examiner can ask you about the urodynamic artifacts, or if the junior asks, what are these? Explain it's just 2-3 lines. These are inaccurate measurements, which can lead to failure of reproduction of the urinary symptoms which the patient is having, and can give false negative or false positive findings. So all the setting should be very accurate. Calibration should be at 0. Okay. Now, cystometry and normal values, we just remember this so that we can interpret the graph normally. This was very important for the part 2 exam. So just remember, in the filling phase, the residual volume is 100 ml. First desire to void at 150 to 200. Strong desire will be at 350. Bladder capacity is 400 to 600. Detrusor rise in the filling phase is only up to 15 centimeter of water. In the filling phase, there should be no detrusor contraction, no leaks. What about the voiding phase? So here the detrusor pressure rise is only up to 70 centimeter water, and uroflowmetry has to be bell shape. Okay. Okay, there was one question, contraindications to urodynamic studies. Anyone would like to answer? Whatever comes in your mind. One we have discussed, infection, yes. UTI, yes. Anything else? Yes.
Ma'am, now you told, ma'am, hematuria.
Okay, hematuria, yes. Anything else? Okay. So someone is writing in the chat box, infection and allergies. Allergies to what? We are using
Stress
no.
urinary incontinence.
Okay. So there are some relative contraindications. Okay, UTI. It has to be treated before starting the urodynamics. Now, if patient is unable to understand the instructions given, or she is having some communicating problems, okay, and she is not able to communicate the sensations, inability to catheterize the bladder, if she's on medications like anticholinergics, so they can be stopped 48 hours before testing. If she is already having an indwelling catheter, autonomic dysreflexia. Okay. Now, how we are going to read the urodynamic studies and the graphs. So what we have to do, just remember a few things. In the detrusor overactivity, what's going to happen? There is only overactivity, no incontinence. So there will be rise in the detrusor pressure and vesical pressure, but no rise in abdominal pressure, no leak. And everything we have to see in the filling phase. Urge incontinence, as the name suggests, incontinence. So there is going to be leak. Urge means there is going to be rise in the detrusor pressure also, and vesical pressure with leak, but no rise in abdominal pressure. Urodynamic stress incontinence, what's going to happen here? Incontinence, there is leak. Stress incontinence, so there will be rise in abdominal pressure, vesical pressure with leak. No rise in detrusor pressure. So whenever you get a graph in the exam, first you check the patient's name. It will be mentioned somewhere. I did not write it here. Maybe I did not have the space. So first thing is we are going to confirm the patient's identity, the name, date of birth, and HS number. Check the caliber. See the filling phase. So in the filling phase, this was the first graph which we discussed. See the vesicular pressure. Is there any rise? No rise. Abdominal pressure. Is there any rise? This green line, no rise. Detrusor pressure, is there any rise? No rise. So this is your normal urodynamic studies. Okay. There is no detrusor contraction, no leak. Clear, everyone? No leak and no detrusor contractions here. So this one is normal graph. Now, coming to the second one, we have, again, check the patient's identity first, the calibration. So here, this is 0, 0, 20, 40, 60, 80. Okay, so calibration is okay. What about the rise in abdominal pressure? Any rise? No rise. Vesicular pressure, the blue line, is there any rise? Yes, there is rise. And when is that rise? With the detrusor contraction. So here is the detrusor contraction in the filling phase. It is more than 15 centimeter water. So again, check for any leak. Any leak is mentioned? No. So this is simple detrusor overactivity in the filling phase. Okay, fine. Now coming to the next graph. Any questions so far, anyone? I hope the graphs are clear now. So here in this one, again, check the patient's name and identity. The calibration is at 0. Then the first purple line, this one, vesicular pressure, is there any rise? Yes, there is a rise here. Abdominal pressure, no rise, nothing. Detrusor pressure in the filling phase, Yes, there is rise. Then check any leak is mentioned anywhere. Yes, leak is here. Urgency and urge leak is here. Okay, and leak is also mentioned here. So detrusor contraction, detrusor overactivity plus leak and rise in the vesicular pressure. So this one will be the urge incontinence. Okay. What is happening here? So whatever graph is given there, confirm the name and identity, the calibration, look at the vesicular pressure, rise is here, yes, abdominal pressure, the rise is here. Detrusor, no rise at all. Any leak? Yes, the leak is here. So this one is your urodynamic stress incontinence. Okay. I hope the graphs are clear. Now you people can read any graph given in the exam. I will share the talks on urodynamics and the new talk related to your urogynecology conditions in pregnancy, postpartum, and the postpartum urinary retention. All right, so everyone has written yes. Thank you, Anam, Aarti, Dr. Rosina. All right. Okay, fine. So this was all about today. Anything? I mean, I thought that let me bring some interesting stations because people texted me about reading the graph. I thought I will bring another station because I already have a YouTube video on the graph. But when we are interacting with each other, that is more important. Okay, so that's
I have a
all
question,
for
please.
today. Yes.
Yeah, before we thanks for your session. Doctor, just I want to ask one question because always I'm thinking about and I don't have a solution to it. What about sensory bladder? Shall we do urodynamic for sensory bladder to differentiate it? Because now it's clear. All your explanation is clear. What about sensory bladder, doctor?
Sensory bladder, the urodynamic studies will be normal because that is not a motor problem. That is the sensory problem. So the history will be nearly same like your overactive bladder history, rushing to the toilet. But there is, so to differentiate between your detrusor overactivity and the sensory urgency, the urodynamics is done and urodynamic studies will be normal. Then what will be your treatment for that condition?
It is the same of urge
Same
incontinence,
like
doctor?
overactive bladder. The conservative management, lifestyle modifications, anticholinergics. Usually surgery is not required in that. There was a structured discussion task on sensory urgency as well.
Doctor, is it only urodynamic? It will be the capacity of a bladder reduced and there is no increase in the pressure of the detrusor pressure. This is was differentiated it by urodynamic.
Mostly urodynamics. That is what we know because the presentation is very much like the overactive bladder. So just to confirm, because it is like now two conditions are there. So you have to confirm what is the condition. So we do the urodynamics. There is no detrusor overactivity, but the patient is complaining of urgency. And urodynamic studies is normal. So that one is your sensory urgency, not detrusor overactivity.
Yeah.
Got it?
Yeah, doctor, I have another question. Yeah, I got it, doctor. I have another question. Doctor, about bladder pain syndrome. Is it sensory bladder or it is another entity? Shall we diagnose by by cystoscope or it could be
What do you think?
bladder?
Not cystoscope is not needed always. It is a diagnosis of exclusion actually. What happens in bladder pain syndrome? That patient will tell you that whenever my bladder is full of urine, I have the pain. When I go and pee, the pain is relieved. What happens? That there is the protective lining inside the bladder. At some places, it is not there. Then that is why when the bladder is filled with urine, in that situation, there is pain. But when the patient goes to pass urine, now there is no more urine in the bladder and there is no contact of that raw area with the bladder. So there is no pain. So that is the diagnosis of exclusion. Cystoscopy is not routinely done.
Okay, that's all. So the pain guide us. If there is pain,
Yes.
will guide us to the bladder pain syndrome.
Yes. Even the Green Dot guideline says we don't do cystoscopy routinely in the bladder pain syndrome. It is just a diagnosis of exclusion. And it's a lifelong condition. We just can't treat the symptoms, and symptoms will be coming in phases. Sometimes patient will be okay, sometimes not. So you have to stop. The food diary is very important, isn't it? In the bladder pain syndrome. If she is taking the spicy foods and coffee and tea and cola, you have to stop that.
Shabana, last question. Sorry, I bother you today a lot. Is it related to the endometriosis bladder pain syndrome, or it's not always?
No, not always. You have to exclude everything, my dear. There is no endometriosis. It is a condition of the bladder.
Yeah.
It is not endometriosis. By the history taking, we have to exclude everything. So
Yeah.
it is not because of endometriosis. It is a condition of the bladder only. Because the protective lining in the bladder is missing at some places. That is why when there is urine in the bladder, it is coming in touch with the raw area now. That is why the patient has severe pain. The bladder pain is there. It is not the period pain. In endometriosis, she will be having period pain also. Dysmenorrhea. Right? In bladder pain syndrome, she will not be having dysmenorrhia. She will be having pain when the urine is filled inside. Okay, I hope the explanation is clear.
Yeah.
All right.
Thanks a lot.
Okay, my dear. All right. Any questions? Anyone? Anything else?
Ma'am, is sensory urgency associated with smaller bladder volume, ma'am?
Yes. It can be associated with smaller volume bladder, infection, inflammation. It has got some psychological morbidity also in these patients.
Okay, thank you.
Okay, my dear. So that's all for today. I hope you like the session, and I hope I've tried to make it as interactive as possible. Okay. Yes, Divya.
Thank you, Dr. Shabana.
Welcome, all of you. So the graph is clear for everyone now, isn't it? So if you people will get urodynamics, I hope you will be able to explain the urodynamics and the graphs with confidence. Okay.
When the recording will be available?
Let it process late tonight. I will share in the groups. Okay, my dears. And thank you, Sanchita, for coming forward and making the session interactive. Thanks to everyone who were writing in the chat box. Okay. All right. Thank you.
Good night.
Good night. Very good night to all of you. Thank you, my dears. And all the best. Keep studying. Just few tips in the end. Get a good study partner. Keep practicing. Revise the recommendations. You people have the knowledge. The only thing is that how you're going to deliver the knowledge in the management part. So it comes with practice. History in urogyny is really very, very long. When I started the preparation, it used to take about 7 minutes for me also. But with practice, it will come in 3 to 4 minutes. All right. Thank you. Bye-bye. Take care.